Use up as much time as we can of Maria's time and get some input from her. Just want to introduce Maria Deprez, previously Burger-Sova, who's coming to us from King's College London, where she's a senior lecturer in medical imaging. And I think many of you know her work very well. She's been a really groundbreaker and leader in fetal reconstructions, mostly for brain, but she also works in both rigid and non-rigid reconstructions, moving into diffusion imaging and fetal cardiac as well too. So we're really fortunate to have Maria visit us and share her knowledge, and is going to present to us today on fetal MRI motion correcting.
Thank you. First of all, I want to thank everybody for coming and to Ellen for inviting me. It's a great honor. So today I would like to talk to you about my work on fetal MRI.
Oh, and can I ask you a question? Do you mind people interrupting between?
Yes, no problem.
Okay, so any questions? Yeah.
Yeah.
Awesome.
So I thought I start from the basics because I did a little bit of work on fetal ultrasound. So this is data from Oxford, and I work with Alison Noble, if you know her, and Julia Schnabel. And this is what we get. This is 3D fetal brain, just to kind of understand why we want to do MRI. So, and this is a good one, I think, because it's a young one, so you can see brain pretty well. But, I mean, I don't have to comment, right, why we would want to do MRI. This is kind of 3D MRI that we can get, and I am sure that people in this room know this really well. So we have a really good soft tissue contrast, so we can see really well how the brain develops and also other organs. And also there is versatility of different contrasts. So for example, this is diffusion MRI, so we can see water diffusion and then see the directions of light matter fibers, right? So there is also many different things we can do with MRI, not just structural imaging. And again, I know that all of you know well what we are dealing, but I still think these videos are like really good to present just what kind of patients we are dealing with. So on the right is a little bit older fetus, maybe around 28 weeks, and they are relatively still, so it's not so bad. But when you see very little one on the left, this is how they are able to move, and we have to be able to image them with MRI. And you all know that MRIs can take a long time. That's like the downside of MRI. So we are at a very difficult situation here. So we cannot really repeat what is done on adults because we can ask them to be still, and we can't really ask fetus to be still, and we cannot ask a mother to stop breathing. She really does need to breathe because she's breathing for 2. So we need to do something to have imaging that is motion resistant. So that was the introduction. I will tell you about the outline of my talk. So I'm very aware that many of you know already a lot about this, but I thought it's still probably good if I review all the theory, how we do SVR, even though I might be saying things that are known, but that way I will get everybody on the same page and I can explain the follow-up. So I will talk about motion correction, rigid and deformable, super resolution reconstruction, and a few clinical applications with fetal volumetry. Then I will tell you about how we reconstruct the fetal diffusion MRI. So this is a bit example of some more advanced modality, and our experience with fetal cardiac MRI as well, imaging moving heart. This is really, really tricky in fetus, but it can be done. Sorry, so I will start with the 3D structural fetal MRI. So just wanted to say that this work has been around for quite a long time. It started in around 2005 or 6. So the methods, there are many different softwares around that do similar things. So it's really like basics that is like already classic. But the newest developments are correcting deformable motion and then using deep learning to fully automate the motion correction. So that's what happened in last few years. So I already told you movement, maternal breathing. So what we do, we have to acquire one slice at a time. We can't do 3D imaging. Or, I mean, maybe we could try, but it won't be very good. So, we need to acquire this slice very fast. to freeze motion in time, and rule of thumb is less than 1 second. That's kind of experience, even though I'm still amazed that it works, because the motion can be on faster scale than that. From what I know, maternal breathing is 2 to 3 seconds, so we are really pushing when it's 1 second. So this is kind of the data that we can get. This is our classical H sequence that these have been used in clinic for maybe now 3 decades, possibly. So this is a kind of standard clinical sequence. This one is ours, so we have a bit thinner slices than you would see in clinic, but otherwise it's the same. You see that most of the slices like here will look very nice. So we have good image, we have some motion in between.
What's your standard resolution that you run?
Well, it depends on the project, but in plane would be 1.25 and through plane 2.5 is like the most common. But on Siemens, I think now that we've switched, we might have 3 sometimes. Like or on a low field scan, we would go to 4.5 even through plane. So it depends on the scan, on the project, how much time you have. All right, so this is the very basic how this motion correction works. This idea comes from François Rousseau and Colin Stadholm. They were very first one who tried to do that. So we have stacks of slices in several different directions, and that was kind of obvious thing to start with, because that's what they acquire clinically, right? I want to have like axial, coronal, and sagittal to be able to do the diagnosis. So actually it was obvious, okay, we have these different orientation, could we co-register them together so that we get some 3D image from it? So they were the first one. Then Joe Heinal, who is actually behind everything I've done here, he's involved in that, even though I don't talk about him too much, but I have to say he's kind of like a brain behind everything that happened at Imperial and then at King's. So they picked it up very, very quickly after. So it's been around in London for a long time as well. So it's very, very simple, intuitive, but it's still what we do nowadays. So we have first volumetric registration. So we select one of the stacks, hopefully a good one that is not too much motion corrupted, and we just align the stacks as if they were volumes. And then we reconstruct 3D from that. It won't be very beautiful 3D, it will be blurry and a bit messy, but then registration can work with something not perfect. So we can then register each slice separately to this volume, and we reiterate several times, and then everything nicely converges to, falls into place. So we usually use just 3 iterations, so it doesn't take long to converge. And of course, it will depend on level of motion. If there is too much motion, it might not converge. So it's not guaranteed to converge, but when we have good data, it does. So, okay, so that's kind of the easy bit. If you know what registration is, this is very easy to understand. Then the question is, how do we reconstruct 3D volumes? Close this. So, because after we align all the slices in the reference space of the head, they are not on the head anymore. So we need to have, so the first methods were like scattered data interpolation, just taking some Gaussian kernel and try to kind of get interpolated data, or at King's they had a B-spline, and it did work, but it produced some a bit blurry images. So it was not completely ideal. So, but then actually it's Ali Golipur who's been here until recently. He came up with this idea to use super resolution. So he is the original mind between super resolution that we all do now ever since. So it was in 2010. And basically idea behind super resolution is that let's try to model how the slice is acquired, and we see what is like mathematical model of acquisition, and then let's try to go back and solve the inverse problem, what the volume would have been if we have all the acquired data. So of course, like MR scanning is not simple, so the modeling is not like very precise or accurate, but even with something relatively simple approximation, we can actually do quite well. So you already know about slice to volume registration, so we can start from the assumption that we know transformation from the slice to the volume. So we know the motion parameters for each time point that is represented by slice. And if we know this transformation, then we can actually take the fetal head to the space of scanner and orient it. So this is what I've done here. Basically, the head was in this position when I acquired this slice, and then we can use point spread function to acquire this slice, simulate the acquisition basically. And then we get simulated slice from this volume. So of course we don't have this volume at the beginning, that's what we want to get, but that's why we first start with forward model and then we solve an inverse problem. Basically, that's the idea. And this kind of, I use this type of approach for all the modalities because it just makes something that seems really difficult to solve suddenly easy, because forward problem is easy to model and then you just kind of do optimization to get it.
How do you determine the full width hat maps? What do you?
Yeah, I'm going to say. So this is the point spread function that we are using, and I have to say this is an approximation, it's not very accurate, but we're still using the same that we did at the very beginning when I tried it for the first time and I asked Joe what I should put in. So you know that when we acquire the slices, we usually acquire them thicker than in plane resolution, and that's to have decent SNR, because if you acquire them thin, it will be just noise. So you can't really have isotropic data easily unless you sacrifice in plane resolution, which is a problem because the structures are very slow. So we want to keep in plane resolution as high as we can, and we sacrifice the thickness of the slice so that we have enough signal with respect to the noise. So as a result, the point spread function will be anisotropic, and we are using 3D Gaussian. And this is really approximation because we know from MR physics in plane it's of course sync, but that's difficult to model, computationally very expensive. There is work of my colleague Bernard Kynes who's done it on GPU, so you can model sync, but it requires Q down GPU. So we're not really using it that much because we continue with our CPU implementation, but that's kind of, it's more accurate if we do that. So this is just like approximately with the Gaussian. I mean, it's possible to do. I think it's good to maybe think about that to do it a bit better. We could have truncated sync potentially. That would work a bit better. But this is what we have at the moment. And then slice profile, we model as Gaussian. The reason for that is that we used to have Philips a lot, and actually they do have slice profiles that are very close to Gaussian. And I think the reason why it was good for fetal imaging that it reduces the SAR. So, but I know that on Siemens is probably not that Gaussian.
We looked at that, didn't we, with Margarita? It's pretty Gaussian.
Is it? As for
It is pretty sloppy, yeah.
Yeah, so I guess it does correspond to what we're using. I mean, sometimes maybe it can be a bit more rectangular, and if you sometimes introduce too much spin history like we've done with diffusion, you can even have it a bit lopsided. But so yeah, I mean, Gaussian is good enough, we thought, and if you want better, of course, it's possible to improve the model, but it really depends on the sequence, on the and all the RF pulse that you choose. So it's not like given.
And theoretically, this may be a stupid question. If you went to isotropic, do you think you could make up for it by just the number of acquisitions you had? Theoretically, like, you know, instead of 9, if you had 18, you know, at a thinner resolution, you think it would make up, but you wouldn't be able to.
So the problem
is
that this is inverse matrix and you're inverting it. If you have noise, the noise just magnitude of noise just goes up. So right. I think not. Yeah. If it's just averaging, yes, but we are not just averaging, we're solving an inverse problem. So we probably would have to go back to just interpolation. But then if you did it isotropic, you maybe wouldn't need to do super resolution. So it's, I don't know, I haven't tried, but at DHCP, Joe really wanted to push resolution, but they did 1.1 in plane and 2.2 through plane, and it was at the very limit. you will see some subject, if you review the data, that the cortex is buried in noise in certain cases. So you really cannot go higher. He really wanted to go higher, and it's just like, it's buried in noise. So I think people have been doing it long enough to know what they should do. They tried. So I think we are with this. Okay, so now the inverse problem. So this is what we have. So we have the acquired data here. And if we have some kind of estimate of the volume, we can simulate what the slice would be if this volume is correct. And then we can compare to the two, and that will give us the objective function. So, and then basically this is iteratively updated using gradient descent. So again, gradient descent is the simplest type of method, and I will show that it's easy to understand, but we've been thinking it because maybe more advanced optimization would reduce the artifacts that we get. So it's easiest to start with, but it's not the most optimal to say. So this is our initialization of the volume, and this is Gaussian weighted reconstruction. That's from the original paper. That's what they use, and you see how very blurry it is. So we use it as an initialization of gradient descent. And so we initial the volume, then we simulate the slice, calculate the error, and then we update the volume. So I will show you in a bit what this update equation looks like. But first, I thought I do a little bit of maths just to so that everybody understands that this is not magic. It's actually quite simple. So here this SJK, it's my voxels of the acquired slice. So my notation that I always keep K is slice and J is the voxel index. And here I have the simulated slice. So this is kind of like equation. So the V is my volume. So I mean just all set of all the voxel intensities in my isotropic volume. VI is one of them. And then this Tijk is the point spread function that has been already like reoriented and rasterized. So that's my spatial point spread function and voxel intensity. So you see that it's a simple linear equation here, how we get it. But of course, then there is how do you get this point spread function. So I have next slide about that. But before that, so we have sum squared error loss. Plus we have regularization term, and we have to have a regularization term because this is inverse problem. And if you didn't put it, then you would get something extremely noisy and you would not see anything, basically. In simulated experiment, when there is no noise, it will reconstruct without it, but with real data, it will not. So about the point spread function, so this is how we design it. So because we chose 3D Gaussian, if you are in the scanner space, it will be always aligned with the plane of the acquisition of the slice. So through plane, we have like the larger axis and the small axis are in plane. So as you can see here. And then we have the transformation to the anatomical space. And once we transform it to anatomical space, you see that the point spread function will become oblique towards the volume. And then we also have to rasterize it on the volume. And this is a problem because that means that each voxel has different point spread function, even though it's same in the scanner space. After reorienting it, each slice will have different orientation. And if you rasterize it on the volume, then each voxel will have different sampling of this function. So none of them are the same. And this is why this is such a computationally heavy task to do, because you need to basically calculate this very big sparse matrix, basically number of voxels in your in your required data is the one dimension, and the other dimension is number of voxels in the reconstructed volume. So it's huge. So as well, it needs to have like a special data structure to only save the like the local neighborhood. So we cannot like have the whole matrix because it wouldn't fit in the memory. And even with the sparse matrix, it's still very memory heavy. So if we have lots of data, so we're always buying lots of RAM to store this matrix. So that's why it requires an expensive machine as well. And then we also need lots of CPU power. So we have lots of cores to make it fast. So I know that like Nestor, for example, uses GPU instead. So we are pushing CPU instead.
Yeah. Why pushing CPU instead? Just because it's more available? Or?
I mean, because it's in C++, and you know, it's to go on GPU from C++, you need to do programming on CUDA, so it's kind of difficult. CPU parallelization is more readily available through libraries, so, and that's what we have. So you can with sufficiently big CPU, you can get roughly the same effect as with GPU. You just have to kind of do the engineering either one way or the other. So, and this is the update equation here. So you see these are my voxels. This is gradient descent step, or nowadays we call it learning rate, right? So but it's the same thing. And this is the point spread function, and this is the error between the simulated and acquired voxel intensities. But we are using robust statistics, so we're not using just an error, but we weight this error, because the idea is that if the errors are too large, we don't trust this data. So basically, this weighted error, this red curve here is what it looks like. So if it's small, it's just we leave it alone. So the P will be 1. And at a certain point, we decide, okay, we are not sure about it anymore. And then we will, when it's large enough, we just put P to 0. So we completely exclude these voxels, and also the same is done on slices. So I simplify this here. We actually have 2 different P's. One is for a voxel, one is for slice. I didn't put like how we find these weights, but it's through EM algorithm. So we fit a distribution of what we think are the outliers and what we think are the correct voxels. And this really helps with excluding slices that are either motion corrupted, because of course motion sometimes can be faster than 1 second, and then you see it in the slice is bad, or it can be misaligned registration, can fail. So these robust statistics make sure that we get rid of all this bad data and we can get nice image.
So do you reject on a slice level or on a voxel level?
Both.
Both, okay.
Both. I mean, Ali did it since the beginning. So the blue line here, that's Ali's robust statistics. So I wanted to push it harder so that we have cleaner images. So that's why I made another option. Yeah. So, and then something that I decided to do as well is intensity matching, because the slices sometimes can be affected by intensities for different reasons. So the reason is, one reason is B1 bias field, that it's more or less stationary in the scanner space, because I think it's primarily generated by scanner and maternal body. Fetus, as it's moving, I don't think changes it too much. So it stays stationary, and if it moves a lot, and you have a lot, like at 3 Tesla, you always have a lot of B1, you will get different shading on the same anatomy. So that's one reason why this is important. Another reason is potential there can be spin history. So if, because of the motion, especially if it's somewhere high up in the belly and the breathing motion happens, then there will be lots of spin history. Another reason is that sometimes there is a little bit of motion and you can just lose part of the signal. You have excitation and it just moves just a little bit, and then you lose part of the signal, so it darkens, right? So, and maybe slice is still quite good, you just have a little bit change in intensity profile. So that's why I found that this intensity matching really helps to give us cleaner images that have less artifacts. And I don't have the equations here, but basically it works like adjusting of the low frequency component, because we assume that these intensity changes happen with very low frequency. So that way we can disentangle it from the anatomy.
Can I ask a quick question? So the B1 bias field, did you see a difference between Siemens and Philips scanners? Or was it the same, similar?
Oh, that's a good question. I think on Siemens scanner, they sometimes don't switch on the correction on the scanner. So that was our experience when we started, that they sometimes don't, because scanner, so I think on Philips, there is something, I'm not really expert on the physics, right? But I think there is something called dream or something like that, that actually on the scan, they have a method to correct it and maybe shimming. So it all depends on these things. And there might be variation with manufacturers, but I think Philips were a little better.
Yeah, I think that's our
things.
experience as well.
Yeah.
Working with other sites and stuff, Siemens has this little worse than Philips that I wanna.
Yeah, I think so.
And how about the low field? Do you see this artifact in the low field as well?
Well, again, depends on how well you do your shimming. Yes, there can be quite strong ones. So, but low field is Siemens again, so same thing. So theoretically should be less, but then again, you need to shim.
But in general, you find the low field better than the high field.
So I think 3 Tesla is difficult because you can't really shim the B1 properly. That's our experience, because from what I hear from my colleagues is that the size of maternal body interferes with the frequency and it just creates really big changes. So yeah, we've done a DHCP on 3 Tesla, but many of us were wondering whether it was the right thing because the data is much difficult to get under control. So if you are lucky and the brain is in the flat area, you get extremely beautiful data. If the brain ends up being somewhere where you have loss of signal because of changing B1, then the data can be very noisy and not very nice. You can also get contrast changes because it's B1 transmit, not only receive. So the flip angle is not the same everywhere. So you can see that you have less contrast on one side of the brain than the other. So there is lots of different issues with 3T.
Yeah, I think we had some very bad cases in 3T as well with this. I sometimes see a radiologist calling abnormality because of this, right? Because if the B1 field is like such that left, right is one is dark, one is bright, sometimes they will say, oh, there's like signal artifacts, signal intensity in the left, and then it might be a fellow or something. But
if you see that, let me know because I should correct them.
Yeah.
And educate them with it.
Yeah.
And Siemens should, but I think it can be switched on Siemens, but like we were trying to do it for cardiac and we had like a medical physicist and she said, I don't want to switch it on because it can be misinterpreted if it's wrong, because if you look at the lungs and left and right are different colored and it could mean there is abnormality and then doctor can get confused. I'm like, surely if you don't correct it, they get more confused, right?
So it's like you can turn on, do you?
I mean, I think pre-scan normalize might help, but I think this is like a much bigger. Much bigger.
It's not helpful. It's very close to coil, I guess.
Yeah.
It's in the middle. A little bit helpful.
Yeah. So I mean, I'm not really expert on these things. It's just what I hear from around me. So, but So, I mean, that's it for the method. So here you can see some results, but I guess you do know this very well because you have lots of your own. So that's our data. And this is like one of the first that we reconstructed on 3 Tesla. This is the good thing about 3 Tesla. They were just so beautiful when it worked out. And this is very young one. And you can see also the original slice and reconstructed. It's much clearer. So it's very difficult to say that whether we really achieve better resolution or not, because theoretically we should be the blurring, the slice thickness. I haven't measured it. I can't guarantee we definitely succeeded, probably a bit at least. But it does look like we probably did.
And what's your final? Is it 0.9 millimeter resolution that you?
I tend to reconstruct 0.75, but that's not to say that you truly have 0.75. I don't think so. It's just like it reconstructs nicer like that. And also you kind of, when you have higher resolution, when it reconstructs, it's easier to see all the edges and stuff like that. So DHCP, they reconstructed even to 0.5. I mean, you can put anything you want, but it's just kind of pointless because it's just interpolation really, because your data has the frequency it has, right? So. All right, so that was the basic SVR. I hope it was helpful because you all know how it works, but now a little bit of maths as well. But question that we asked ourselves a few years back was, what about other fetal organs? We had this big project, I find, when they started looking at other organs, not primarily brain. And it's like, well, obviously we need to model deformation then. Because brain only changes position and orientation because skull is hard unless you want to reconstruct the face as well, then it's different. But if you're only looking at the brain, then we can get away with rigid registration, but with fetal body, we do have deformation. So we thought, okay, we would like to model the deformations as well. And it turns out that the way that everything is designed is actually not complicated because we just can switch the rigid for non-rigid registration and everything else is just working as before. Even the point spread function, it will be deformed, but you calculate it exactly the same way as before, you just deform it as well. Only thing that we added was patch-based robust statistics. So now we're looking at patches, and this makes sense because when you do deformable registration, part of the image might be well aligned, but another part might be misaligned. And it does happen because non-rigid registration doesn't really work very well at the edges of the images. So that is a problem. So that's why this patch-based helps us to get everything under control again. And you can see here a good case, what we are able to achieve in 3D. So we can reconstruct the fetal body, but sometimes if there is not too much motion, you can even reconstruct the whole uterus with it, as is, just with the same software. This is something that is not solved to me because I think we can do better for whole uterus because you have lots of discontinuous motion and DSVR doesn't model anything discontinuous. So we will just, everything is continuous, but we will probably just exclude the parts of the images that. So it's already produces good results, but I think there is more work to do on whole uterus. So it's something I hope to work on soon.
And for reliable results, how many stacks do you usually put in of the fetal body?
I think it really depends on the project, but 6 probably as a minimum.
And do you throw slices initially? Do you that are bad, or does the algorithm do that to throw the slices out?
So the like original SVR, if you just have the C++ code, doesn't do anything like that. You need to just give it what you think is right. So if you do it manually, you do the masking and then you review all the stacks, you see that all are aligned and you throw away the ones that look bad.
Yeah.
And sometimes clinicians still prefer to do that because they feel more in control. So we have I'm going to talk about that now that we have a deep learning wrapper. I mean, partly deep learning, partly not. I didn't put all the details. So we have some kind of, Alena has a Docker where there is more pre-processing steps. So we are looking at the amount of motion within the stack and try to find out which one is the best and which one we should use. Also registering everything together and then trying to see which one fits better, like with cross-correlation. So there is a little bit of simple pre-processing steps, but they can go a long way in full automation of this process. So this is done through simple image processing methods, but there are things that we couldn't really solve before we had deep learning, and that's, for example, masking of the organs. So here you can see a baby, the kind of baby that was in my movie on the left side, early gestation and really having lots of fun inside. And you see that in each of the stacks is in completely different position. And if you try to do something like that, you still have to do manual mask, let's say for the brain. But even if you do that, you try to put that to SVR, you just really don't get anything nice. So for example, we've done this for trunk and this is the kind of output we got. So that's clearly not good enough. So before we had deep learning, we would just do everything manually, draw the mask and then landmarking to reorient it. But since deep learning, this became much easier to automate. So this is Alena's approach. So I know we have all the fancy registration like SWORD and other methods that done that, but she just took a unit and she decided, so like there is a series of units just for a segmentation of brain and trunk. And then here in this example is trunk, just separating it into more labels. And once you get different organs, you can take centroids and reorient it to standard orientation. And then you know you have everything oriented in the same standard orientation, and it's a good starting point for SVR. So this is what we have done, and we do it in 3D. So people have been doing like masking or this kind of in 2D, but we found it a bit unreliable. And as well, depending how you acquire your data, so we have several passes in a stack, so we split them into packages, but if you just have clinical scan of 6 slices, it will be all ascending. So if they're all ascending, the baby wouldn't have had so much time to move, so the 3D information is quite good, and if it's not, usually it's broken. So we figured that if you just take like a stack of consecutive slices, so in this kind of acquisition, we have 4 passes of that. So we split it into 4 packages, and that's the package then looks something similar like clinical data. Maybe it's even a bit thicker, but then we can rely on it being relatively stable in terms of motion because it's consecutively acquired, and we do it in 3D. And that seems to work. Not 100% of the time, I have to say, but very often. So you can get it completely automatically most of the time. So that's for that. And here you see even this very moving baby, this is the reconstruction. So of course it's not as good as if you have perfect data, but still you can get the recon work. So that's all for SVR. I just wanted to show you a few applications that we've been doing very recently. So this is Helena. So she is coming here in November to work with Ellen for a couple of months. And she's been looking at segmentation of transient layers in fetus. So fetal brain is not white matter and gray matter like in adults, but we have some other tissues that in particular something we decided to call proliferative zone because there is some confusion in literature what it means, but that's this very dark part, germinal matrix, and some people call it ventricular zone, some subventricular zone. So that's why I was like, okay, stay away from this naming proliferative zone. That's where we have stem cells that make neurons. And it's very dense, so it looks very dark. So that's one layer that we segment. And there is periventricular white matter, and how we define that is the high-intensity white matter, so it will be water-rich. I think it's probably lots of extracellular matrix. And so parts of white matter are a bit darker, part are brighter. So the brighter on T2 means more water, and that's what we call. Also subplate, of course, which will be bright just. That was done by our clinical colleagues with some students, and they segmented it manually. We're still refining that, so it's not completely ready. And then we propagate the labels from the atlas into the images, and we train the network with these propagated labels. Attention unit is our favorite because it's a little sharper than classical unit. And then Helena has done some volumetry with it, and we had not many, but a few subjects with ventriculomegaly, so we wanted to see what happens to the volumes, and we already knew that cortex gets bigger in ventriculomegaly because Vanessa found that already a while ago. But we found that also the proliferative zones do, and primarily on the side where there is ventriculomegaly. So they are mostly left-sided. We have just 8, so it's not a big study. It's very preliminary, but 6 were left-sided and 2 bilateral, and it came significant only on the left side. So it does seem something is going on, that there is actually more proliferation and thicker cortex.
And it's more volume, not thickness, because you've got a bigger surface area.
That's right. So thickness is not, I think for cortex, they did look at thickness, I have a feeling, but yeah, this is just volume rather than thickness. Yeah. So it might be because ventricles are larger, it's just more of it. Yeah. Now cardiac application. So this is David Lloyd. Maybe you know him. He, for his PhD, applied SVR to fetal heart because I think there is a need in diagnosis of congenital heart disease to see the structures in 3D. And he published a Lancet paper showing that actually cardiac vessels can be better characterized on 3D MRI than on ultrasound and then on 2D MRI. So 2D MRI actually was not useful for this application, but after reconstruction it was useful. So it improved not necessarily diagnosis itself, but confidence in the diagnosis. Basically, the cardiologists become more sure what is wrong with the vessels. And here you can see, like, this is actually not so difficult to see, but it's easy to show that there is double aortic arch. So there are two instead of one. It shouldn't be like that. On the left is as how it should be on the right. And sometimes there is a right aortic arch, and the smaller vessels can also be wrong, basically. So there is lots of different variations on that, and they really need to see. So we tried to automate these segmentations because originally they were all manual binary segmentations, and we wanted to have automatic segmentations. And when we tried to do just binary segmentation, it just was not working because we struggle with resolution and the vessels are very small, so we couldn't get the small vessels. But then we had a breakthrough that with multi-label segmentation, we were actually able to get the vessels quite well. So we have an automated method. And then also this is work through collaboration. I don't know whether you know Pablo Lamata is my colleague at King's, a professor. He works on cardiac modeling. And they've done statistical shape model for prediction of coarctation of aorta. So coarctation, the aorta is topologically the same, but it doesn't have the same shape. It's a narrowing of the aorta. There is something going wrong with the flow, and these babies can die after birth because there is like transition from placental blood flow to neonatal, and basically this transition tend to not happen properly for them, so they need surgery. And it's really difficult to predict because some fetuses have narrowing of the aorta, but actually they are fine, and some others would die. And it's very difficult for the cardiologist to work out what's going on. So, and it turns out these shape models can improve the differentiation between the babies who get it or not. So this is kind of really nice application that came out of this work.
Do you use a specific sequence for cardiac, or is it that through haste?
It's haste, but they like to reduce the echo time to 80. For brain, I think they were thinking we used to have 120, and now they even moved to 180 for brain because there is lots of signal. But for cardiac, they prefer to go lower echo time. But otherwise, it's exactly the same. And we also now using the deformable for it. It's you can do with rigid because it's still within the rib cage, so it works okay with rigid. It works just a teensy bit better with deformable. And final application for this part, and I think I'm really overrunning terribly because it's 45 minutes already. It's Lisa's story. She's an obstetrician and she does lots of different studies. And in this study, she showed that the thymus has a smaller volume in babies that go on to deliver preterm. So she recruits at-risk fetuses, and some of them go to term, some not. And she did see this. She thinks it's because of potential infection. Yeah. It might happen. And she's looking at lots of other things as well, lungs, adrenal glands, and other organs as well. So she's doing the whole program of this. So that's amazing just to see what could be done in the future with this type of methodology. Okay, I now really need to speed up, I think. So let's have a look what happens with diffusion of the fetal brain. So we want to study, do diffusion to study developing microstructure and connectivity. And here you can see an example of the HCP dataset. You can see here the orientation of the fibers and here whole brain tractography. So we are able to do that nowadays. So I have a little bit of introduction to diffusion MRI, which might be redundant here. I'm not exactly sure, but basically diffusion measures the diffusion of water in particular direction, and then diffusion signal can be understood as a function of spatial location and sensitization gradient. So it's a function on a sphere, and here you can see example of the diffusion signal. And that's why it requires multiple acquisitions, because we need to sample these orientations. And the diffusion signal will be perpendicular to the white matter fiber directions. And then we need to apply something to get the direction. So we are using a matrix, work of Donald Tournier, who is my colleague, to get the orientation. So one of the problems that we didn't have with haste and we have with diffusion is that we are using echo-planar imaging because it's fast, and we need to go fast because we need to acquire multiple volumes. But the price we pay for fast acquisition is geometric distortion. So we need to have something to correct distortion. And you can see here example, this is actually bubble in maternal gut, and it distorts the brain like this. So it's usually air tissue interface that is causing the distortion.
I hear it's vitamins with iron.
Yeah, that's another problem. So basically we have corruption by both motion and distortion now. And I mean, there are some acquisition-based techniques that can be used, and actually in DHCP, that's what we have done, but I will present the registration-based technique instead, because I think advantage of that is that if you didn't acquire anything extra, you can still correct it with registration. So motion will be corrected as before using slice to volume registration, and distortion will be corrected using deformable volume to volume registration, but I will show you how we need to constrain this registration based on MR physics for it to work properly. So to do that, we need to understand what is B0, what is inhomogeneity looks like, and basically distortion is due to inhomogeneity of the main B0 field. And as I said, generated by interfaces between air and tissue. And this shift, and basically it results in shift of voxel in only one direction, the Y in the slice, so the phase encoding direction. And also, if we are away from the air and tissue interfaces, it will be smooth and obey Laplacian equation. That's a bit harder actually in children and adults because we have ear canal and air goes very close to the brain. In fetus doesn't happen because fetus is within water. So actually you have less distortion in fetus, but it's still there. But we can have a little bit easier situation in terms of smoothness of the field than we have in adult or neonatal imaging. So basically, the approach that we have taken, it was me and Joe designing this together, was to take the reconstructed structural data because they're not distorted, and then register this EPI, so these are B0 images without the sensitization gradient. We start with that, and register them with slice to volume registration to the structural, and once we know where they fall, we can simulate undistorted slice. And then we can register only in phase encoding direction. We can just push the image back to the place, and usually it needs maybe 2 or 3 iterations to refine the motion parameters after it's been corrected. And also, so it's actually very special registration because we're registering like 3D images, but only in one direction. And it's very important to constrain it because the contrasts are not exactly the same, and you would get lots of artifacts in your deformation field without it. And second constraint, we have the Laplacian constraint. So we smooth the field with Laplacian. And here you can see this is acquired field map, and this is the one from the registration. And this is if it's constraint to only phase encoding direction, but without Laplacian constraint. If it was in 3D, some people just use 3D, you get lots of like ups and downs everywhere. It's just not very good quality. So that's why we found that constraining it really improves the performance, and it does work quite well. And then, we just done the simplest case that we estimate the distortion field from the B0 stacks, and then we apply it to diffusion sensitized stacks. There is a word of warning that if somehow the distortion changes in time, then it wouldn't exactly work. So maybe, but we never really got to working on it like stack by stack, so it's possible. But at 3 Tesla, we've seen such huge distortions that it was difficult to do it with registration. But if the data is not too disrupted, I still think it corrects the majority of the distortion. So retrospectively, we can still correct the data if there was nothing done on the scanner.
Did you multiple B0s throughout the application?
Yes. So you can use multiple B0s. And method could be extended also to work on the individual volumes, but we haven't done it. So there could be more done if it was useful. Okay, so if we have now motion correction, we have distortion correction, and then final thing to do if we do both is to work out how do we get diffusion data on a regular grid. So we have a little bit more complicated problem because we have scattered data not only in space but also in orientation, because you have a gradient table at the beginning that is always the same, but each slice then rotates, and basically with respect to the fetal head, the gradient rotates as well. So you end up with scattered gradients. Each slice will have their own gradient. So basically what we need to do, we need to have a parametric model to kind of put everything on the grid, and we chose to use spherical harmonics because kind of to make it consistent with MR-tricks and with all the post-processing after. So here spherical harmonics are functions on the sphere, and here is like a visualization of what basis function look like, and then we just do linear combination of this basis function, and it gives us like any function on the sphere basically, and you can make it more or less flexible by choosing different order of spherical harmonics. And then the forward process will have one extra step. So this is what we want to get, our spherical harmonic representation of the diffusion signal. Then we can just sample based on the gradient we want to generate. We get a 3D volume, and then we position it in the scanner space, and we can use point spread function to simulate the slice. So that's the forward model. So once you break it down like this in the step, the forward model, then actually reconstruction becomes just the same thing, just the equation is a little more complicated, but you get the same type of thing as we had before. So these are the spherical harmonic coefficients. Then this is the 3D signal for particular gradients. So why are the spherical harmonic basis functions that you can sample for particular direction? And if it sum it up, we get the 3D signal, and this is T is the point spread function, the same as was for structural. So this is the simulated diffusion signal, the slice, and this is acquired slice, and then we have the iterative optimization gradient descent, or in DHCP data conjugate gradient descent, that is a bit better. And it's the same thing, basically. And here is my results, some examples at different gestational ages. This is what it looks like. So we can see some fiber crossings, which I cannot 100% guarantee that they are perfectly all right, but they're not too bad, I think. And and you can see what happens to the directions. Like we can see that there is orthogonal orientation with respect to the cortex, which is a well-known fact. And also we see as it folds, it's kind of the orientation folds with it. And slowly as the baby is getting older, this orthogonal, or what we call the radial orientation in the cortex, disappears bit by bit. And here is the study that we've done with DHCP data. So we wanted to look at microstructure of individual transient fetal layers. So we took the reconstructing diffusion signal, and either we did diffusion tensor fit or a multi-shell, multi-tissue constrained spherical deconvolution, and we got this microstructural map, so FNNDSC, and this is tissue fraction and fluid fraction that is not completely standard, but that's what we had, and we could see this pattern in a whole brain MD, which I thought was quite interesting, that actually MD or fluid fraction actually look very similar to each other, and I think they represent the amount of water in the tissue, and we can see that tissue is getting more and more watery up to around 28 weeks, and then it starts getting less watery. That's what we found, and in individual layers, this peak happens at a little bit different times. And then tissue fraction actually just has opposite trend to fluid fraction, so it doesn't give us much extra information. And then it was interesting to look at cortical plate, that we see FA going down, but tissue fraction going up. And I think probably explanation for that, FA goes down because we are losing this radial orientation, but the tissue is probably getting denser and has less water. So this shows nicely that these two things don't show us the same tissue property. And this is a result from a master's project. We try to compare the microstructure for ventriculomegaly. So it was again a small study because we have only 6. So it's not like very precise, but we did find differences. And again, it's in cortex and proliferative zones. We see decrease MD. And for proliferative zones, it was again only the left side, not the right side, that became significant. In cortex, it was both sides. So it's too small to be sure, but it does look like something is happening in ventriculomegaly, not only with volumes, but also with the microstructure. Something is different. So that's it. I'm running out of time, but I don't have many slides on the cardiac. So I'll just quickly show you. So the work, this is work of Joshua, who was a few years back a PhD student with Joe, and he is an expert in cardiac, in fetal cardiac, because he's been already working on that in Toronto at 6 kids. He did then PhD with us to do this 3D imaging, and he went back. So he's there. If you want to know more about it, please contact him. So I was helping him with SVR, so I want to show only the SVR part because the input to the what he's done as big part of his PhD was just to getting this 2D plus time in his stack, and his approach was KT sense, and I'm not expert on it, so I'm not going to tell you about it much because that's very much MR physics task. But what I was helping with him was how to then compose these 2D plus time slices into the 3D plus time. So we again have the kind of same strategy. We first look at the forward model. So this is our 3D plus time. Then we use the time point spread function to generate particular cardiac phase. And there was a sink in this case because it was KT sense. So that if we, in other approaches, there might not be any point spread function. It might be just sampling. But anyway, we extract the cardiac phase, and then we use the slice to volume registration to find where it is in the scanner, and get the simulated acquisition, and then the story is the same. So it's just basically expanding the same approach to more modalities. And very recently, we got a Doppler-gated device from Norse Medical. I know that you have one here. They have one in Toronto. Lots of people have bought it. So we've been experimenting with what we can get out of it. And actually, clinicians love it because, you know, like KT sense was really complicated. Like image-based gating is difficult. You need lots of steps. So they just plug the device in, and then the scanner works as if it was ECG from the adult. So everything is done on the scanner, and you just get the data. Of course, it's not that simple. So we use just the basic BSS BSSFP gated cine sequence, like we would do in adult to get 2D plus time. But sorry, this movie is not exactly the right speed, but you can see the type of data that we get. So it's not very high quality. The reason for it is that we have very basic sequence, and also we need to stay on the slice for a long time. So we stay on the slice for 4 seconds to get enough time resolution, but you have quite some motion potential during 4 seconds, and it's still not enough for good contrast. Because when the Norse Medical will show you these very beautiful fetal cardiac images, they actually stay on the slice for 30 seconds. And how often does that work?
Yeah.
Right, so it's actually not a solved problem yet, but saying that, we have been working on SVR just to improve computational efficiency. So we now have this 3D plus time recons in 7 to 10 minutes. We are working on full automation as well. So we're building a Docker. And of course, future work is to work out, could we do better on the sequences? And I think we probably will be able to do better. Some people do spirals. Krishnan in San Diego, they do radials in Toronto, where they are able to exclude motion corrupted bits of the slice. So I think that's something that needs to happen now. Like, how do we go about improving the sequence to get better image quality? But saying that, clinicians are not complaining because they get to measure stuff from this a bit too blurry data. So here is some initial experience with using this data. And this is work of Thomas Woodgate. He presented this at ISMRN this year. So they measured stroke volume from like volumetry and also using flow, 2D flow. And there was a very good agreement, especially in left ventricle. In right ventricle was a little bit less good, but still, like, for the initial result is not bad. So that means that we are actually getting it right. So it means that it's useful for measurement already, even though images don't look amazing. They actually do have clinical information in them that can be very useful for diagnosis. And we are now acquiring this type of data 2 to 3 times per week. And David and Tom have a project on it, investigating what we could diagnose with it, basically, because we didn't have it before. So it's no established protocol, but we think that it will be important for example, the coarctation of aorta, because the flow is different. So we will work out biomarkers with time. And final minute of your time is, I talk a lot about cardiac, how hard it is to get good resolution. And I showed you at the beginning, ultrasound not so good. Well, not exactly the case for fetal cardiac, because here, this is the lovely G scan. So I don't have a movie, but look at this resolution. And this is 3D stick, which is like state-of-the-art of 3D ultrasound. So when you are in plane, you get not as good as here, but relatively good resolution. But when you are through plane, you get mess. So basically, current 3D ultrasound acquisitions just not good enough for clinical practice. And also, if there is motion, that get disrupted even more. So what we are thinking is to do SVR for a 3D plus time cardiac for ultrasound. And I know that you're looking at the brain as well, and I don't know what that will be helpful for. Perhaps it will be, but for a fetal cardiac, actually MRI is just not there where we need it to be. So we think that, I think it's going to be really hard. I'm not sure how well it will work, but if it does, then it will really help. And we might be able to see the vessels, we might be able to see the valves that are just so blurry on MRI because they are so tiny. So this is basically future work, and we started on the 2D to 3D registration. We haven't done recons yet, but it's Paula's work, and we can see that it can work. But I think there is lots of problems to solve, like shadows and stuff. So it's really just the beginning, and we'll see where it takes us. Basically, that's it. And that's it. So I want to say thank you to all of you for attention, but also huge thank you to my colleagues because we are a big group and everything happens through collaboration. So of course, lots of these things is happening with contribution of many people. I want to say thank you to my group and to our hospital that allows us to get data and our funders. And that's all.
Great. Thank you. I know we've been asking questions, right?
I have a quick question. So for volume reconstruction for the same subject data set, when I use the different reconstruction tools, of course, the output looks a little different, especially one result looks more blurred compared to other results. So I'm just wondering what makes the difference of the smoothness of the output volume.
Primarily how you choose your regularization, I think.
Is there any specific parameter in your?
Yes, so I'm using something that is called edge preserving regularization, is in between L1 and L2 norm. So in a work in Lausanne, they used L1 norm and that gives you sharper edges. Some people use L2 norm and that gives you blurry. So that's the primary thing. There might be some differences in how point spread function is used. So there will be some minor differences causing this. Also, density matching. So we would expect some intensity artifacts potentially in the recons.
Is that in the tool or will it change some current value when running that program?
So I mean, I can't talk for the others, but for us, yes, like you can change the parameter, it's called delta, to make it more like L2 or more like L1, if you want.
Any questions? I know a lot of people are going to have one-on-ones as well too, so we're getting lots of chance to pick your brain.
And we are very much out of time as well.
Great. Well, thanks everybody, and thanks
Thank
again
you.
for your talk.